Today's grand round topic is originated from our compliance department, and Dr. Williams from Integrated Medicine educator, Troy, Pennsylvania. There is no conflict of interest. She is an integrative family doctor who practiced family medicine for 13 years in Chicago area, then in Pennsylvania. Graduated from Cornell, completed medical school in Chicago, and family medicine residency through Northwestern University. Dr. Williams completed a fellowship in integrative medicine through the University of Arizona Center for Integrative Medicine. She is a full-time parent of 3 who also enjoys yoga, coaching, gymnastics, and soccer, educating people about holistic approaches to healthy lifestyles. She is passionate about the integration of conventional and complementary medicine approaches, improve health and well-being, and frequently lectures on holistic integrative medicine topics. Please welcome Tricia Williams.
Thank you. Thanks very much for the kind introduction, and thank you for the invitation to speak with you today about PANS and PANDAS. My goal is to increase the awareness of these disorders. By the end of this hour, I hope you will leave with the thought that if a patient has an abrupt onset of psychiatric symptoms, the first step ought to be to rule out organic causes. Here is an illustration showing the hierarchy of the illness. PANS is the overriding category for pediatric acute-onset neuropsychiatric syndrome. And then, depending on the cause, infectious or non-infectious, it is further divided and further designated. PANDAS is the subgroup of PANS that is associated with streptococcal infection. PANDAS is pediatric acute neuropsychiatric disorder associated with strep. This criteria was created in 2010. The disorder was initially described in 1998. I am grateful for the opportunity to increase awareness about this little-known disorder. I'm not a specialist in PANS. However, I am an integrative family physician, and the care of this disorder crosses many specialties. It has been referred to as an orphan condition because while all these specialties are frequently involved in the treatment of a child with PANS, none claim it as their own. PANS is an autoimmune disorder with psychiatric, neurologic, and rheumatologic symptoms, typically triggered by an infectious disease. It is primarily a condition of children, but the symptoms and behaviors can persist throughout adulthood and lead to a lifetime of suffering, especially without appropriate treatment. I have come to be familiar with this condition through my personal experience with my own child. Our story illustrates the limited awareness and associated struggles with diagnosis. My daughter had a classic presentation, but I and her other providers were unaware of PANDAS. She was an 11-year-old with typical neurodevelopment and no significant medical problems aside from mild vitiligo and some food sensitivities, when abruptly her behavior changed while we were spectators at a wrestling match. She became suddenly fearful and agitated. She was hiding under the seat, making grunting noises and banging her head with her hands. She would not speak except in moans. I thought she must have a sudden fever or low blood sugar, but neither was the cause. This was just the first episode of what became a frequent occurrence over the next 9 months. Symptoms ranged from mild irritability and agitation to panic attacks. At times, the behavior could last for less than half an hour. Other times, it could go on for hours on end, ending only with the exhaustion of sleep. Her overall mood remained irritable. She showed mental and emotional regression, such as playing with toddler and preschool-aged toys. She lost initiative and desire to participate in activities, and she fatigued from her usual sports. She became unmistakably indecisive. Even simple choices like deciding between orange juice or cranberry juice, or deciding what to wear to school, could bring on panic and cause her to get stuck in an obsessive thought pattern. As a gifted student, she showed no significant decline at school, but returned home exhausted, complained of body aches and joint pain, and often desired to stay in bed. It was frightening and heartbreaking to watch her suffer. Extreme rages could not be consoled by any of our interventions. She was unable to describe how she felt or what she was feeling or what was happening to her. Her psychologist tried cognitive behavioral therapy and taught us parent management techniques to treat OCD, but was unable to make any progress over several months. With the psychologist's help, we tried techniques recommended for children with autism. We were discouraged when the therapy seemed to trigger and even worsen her mental state. Her family physician tested for Lyme, rheumatologic conditions, and other physiologic illnesses. We did a brain MRI in fear of a tumor presenting itself with such dramatic behavioral change. I spoke with numerous colleagues in family medicine, pediatrics, psychiatry, emergency medicine, social work, and multiple holistic physicians. No one thought of PANDAS. We did not know about it. Thankfully, her psychologist reached out through a listserv of her colleagues, and someone replied, "Have you considered PANDAS?" I immediately began reading and researching to see just what this was. I will be forever grateful for that suggestion. In retrospect, it was easy to diagnose. Our child had strep pharyngitis and was treated with azithromycin due to a penicillin allergy just 10 days before that first episode at the wrestling match. We now understand that her sudden behavioral change was due to an autoimmune reaction resulting in autoantibodies attacking the basal ganglia. It had affected emotional processing, decision-making, motivational planning, and left her with fatigue and pain. While waiting to be seen by a specialist, we treated her with cephalexin for 30 days. About 7 days in, her symptoms abated, and by 2 weeks, she was back to her baseline. Here are the diagnostic criteria for PANDAS. The hallmark of this illness is its abrupt onset of co-occurring changes that include both neurologic and psychiatric symptoms. There is an acute onset of OCD or a severe food restriction. The abrupt onset is the key distinction. This has been described as a lightning strike. The parents report that their children are dramatically and suddenly changed. They can pinpoint the change to a specific date. This is unlike more typical onset of OCD or tics, which we see a gradual increase over weeks to months. OCD in children can be difficult and complex to diagnose because compulsions may resemble oppositional behavior when children become upset and act out when their compulsions are thwarted. Many compulsions are either mental rituals and therefore difficult to observe, or extremes of acceptable behavior such as hand washing. The abrupt onset of a severe food intake is another possible presentation. These children may meet criteria for avoidant restrictive food intake disorder. They often have fear of vomiting, sensitivity to taste, smell, texture, or a fear that their food is poisoned or spoiled. The second criteria is there is a concurrent presence of additional neuropsychiatric symptoms with a similar severe and acute onset. For diagnosis, they must have at least 2 of these 7. However, most of these kids have such a pervasive change in behavior that they're affected in all of the areas, and by surveys, most kids at least in 5. The anxiety can be constant, or it can be a new onset of age-inappropriate separation anxiety. There is emotional lability and depression, irritability, aggression, and severe oppositional behaviors, frequently with episodes of rage and irritability. What appears to be oppositional behavior can be a manifestation of OCD. Symptoms may be very severe. Children may run away, hurt others, refuse to eat, and experience suicidal thoughts and urges. These children can be extremely irritable. They have their family walking on eggshells trying to avoid rages and tantrums. A research survey has shown that the stress experienced by families of children with PANS and PANDAS exceeds that reported by caregivers of patients with Alzheimer's disease. Behavioral and developmental regression with interest in baby toys, baby talk, refusal to groom in previously adolescent children who are bathing, tantrums, and clinginess. There is usually a sudden deterioration in school performance due to impairments in memory, visual spatial skills, math calculations, and executive functions. There are motor or sensory abnormalities with sensory hypersensitivities, which the children suddenly become intensely and uncharacteristically bothered by smells, tastes, sounds, lights, textures. This leads to extreme difficulty with ADL, not wanting to ride in cars, not wanting to brush their teeth, not wanting to eat. They can have neurologic abnormalities in the motor area as well, with significant handwriting changes. Many of these children also present with tics and clumsiness. They can have mild coriform movements, which are small, irregular, arrhythmic movements in the distal muscles. They have somatic signs, including sleep disturbances, and can have a new onset of enuresis or urinary frequency, which can be very helpful to distinguish this from other more garden variety mental illnesses. They may have to urinate up to 8 to 10 times an hour, and it's not explained by the OCD alone, and it also has normal urinary analysis and no other urinary dysfunction. The third criteria is very important, and this is that the symptoms are not better explained by another known neurologic disorder or medical disorder. Those were the criteria for PANS. This is the criteria for PANDAS. It is very similar. The only really appreciative difference is the temporal relationship between onset of symptoms, exacerbations, and group A, strep infection. Just as with rheumatic fever, the symptoms typically begin within 1 to 4 weeks after infection. Episodes then often remit in 6 to 16 weeks, but they can recur. They can be triggered by another strep infection or even exposure to other illnesses that are not strep, if the immune system is activated in response to other pathogens, such as viral infections and more often mycoplasma. We don't see as much rheumatic fever anymore as previous, but OCD-like behavior has been described in association with streptococcal infection as far back as 1894 by William Osler. We now have a recent American Journal of Psychiatry study which was done in Denmark with over 1 million people in a registry. All of the individuals who presented for infections of the throat were either found to have a non-streptococcal infection or a streptococcal throat infection. And they have found that individuals with streptococcal throat infection had elevated risks of mental disorders, particularly OCD and tic disorders, much more than those without a strep infection. That study was just published in 2017. There is some controversy surrounding this diagnosis, and I want to just mention that right away. When the connections between infection, inflammation, and PANS symptoms are not suspected, the opportunity for clinical treatment may be missed or delayed. There has been controversy since it was first defined. This controversy and associated limited awareness is at least part of the reason why we missed it in my daughter. It is a difficult disorder to study for many reasons, and many questions remain. The remitting and relapsing course makes treatment effect difficult to gauge. Conflicting findings may also be due to indistinct inclusion and exclusion groups. Also, our groups with tics, our Tourette syndrome, OCD, and PANS really entirely separate entities. Is there a continuum? Is each an autoimmune condition? What mechanisms actually cause autoimmune conditions anyway? We're still learning these things. If these are autoimmune disorders, then can the psychiatric symptoms be treated with immunomodulatory therapies? Are we missing asymptomatic strep infections? And are these more often resulting in problematic behavior in our children than we realize? Are we overusing antibiotics? Are we overusing psychiatric drugs? How does organic disease cause psychiatric symptoms? And how does the brain really control emotions and behavior? In an attempt to address many of these concerns, experts convened at the NIH in 2010 and developed the current criteria for PANDAS. Research is continuing and evidence is continuing to accrue and supports PANDAS as a distinct post-infectious autoimmune entity which does seem to respond to immune and microbial therapy. In many areas of medicine, we treat patients with the best evidence we currently have, even when the pathophysiology is not fully understood. Unintended consequences of not doing so can be significant. The risks of treatment versus non-treatment must always be considered. The etiology of PANDAS is thought to be a dysfunctional autoimmune response to strep. It is similar to other post-strep syndromes which we know, including acute post-streptococcal glomerulonephritis, rheumatic fever, and Sydenham's chorea. The proposed mechanism for each of these is that of molecular mimicry of group A strep, which stimulates production of antibodies that then cross-react with antigens in the host tissue. In PANDAS and Sydenham's chorea, the antibodies cross-react in the basal ganglia of genetically susceptible people and produce a combination of neuropsychiatric symptoms that we see. This is an image of the proposed mechanism of molecular mimicry. Group A strep shares amino acid sequences with certain human tissues, so the antibodies recognize and mistakenly attack host proteins. In rheumatic fever and Sydenham's chorea, it is known that there is a prolonged persistence of these antibodies compared to children who have uncomplicated pharyngitis cases. There is also a significant genetic predisposition, and certain strep strains are known to be more rheumatic and more nephritic. These three same mechanisms, that of specific strains, genetic susceptibility, and prolonged persistence of the antibodies, are also proposed for PANDAS. The basal ganglia are subcortical structures which influence inhibition of motor and behavior symptoms. We have evidence of dysfunction in the basal ganglia on imaging studies with both MRI and PET, where they show volumetric changes in basal ganglia. They also show microglial activation, which is a sign of inflammation, and microglia also play a role in transmission of neurotransmitters. We also know there are specific anti-neuronal antibodies which react with the human basal ganglia. They are listed here, and I will discuss those a little bit later. When we look at the functions of the basal ganglia related to its structure, it is not surprising to see how inflammation in this area may lead to the constellation of symptoms that we see. The basal ganglia are relay stations through which neurons run that control mood, emotion, procedural learning, motor movements, cognition, and sensory processing. As we disrupt each of those, we see how we can cause the symptoms that we see in children with PANDAS. These children have been compared to patients with basal ganglia strokes with a symptom called abulia. Abulia describes the loss of willpower, the lack of initiative, and difficulty with decision-making. There has been some discussion within the community to change the name from PANDAS to post-infectious basal ganglia encephalitis to better define the etiology. We can also look at other immune diseases that have psychiatric presentations to help us understand PANDAS, such as autoimmune encephalitis, anti-NMDA receptor encephalitis, inflammatory back pain, Behçet's, Hashimoto's thyroiditis, and neuropsychiatric lupus. In lupus, 25% of lupus patients have neuropsychiatric symptoms, and OCD is very common in SLE. Autoimmune psychoses often have atypical presentations with sudden onset and cognitive decline. Neurologic exam and MRI can be normal, despite abnormalities on CSF and brain biopsy. These are often resistant to typical psychiatric medications. There are cases where we cannot confirm positive biomarkers in encephalitis, either because the antibodies are not detected or they are antibodies that we have not yet identified. So a clinical diagnosis is made. These cases are also called seronegative but probable. When they are diagnosed and treated early, they respond to immune modulating therapy. The later the diagnosis, the less likely there's full recovery. From experience with these other disorders, we see symptoms vary significantly with the age of onset. Adults are much more likely to have psychosis and cognitive decline. However, kids are more likely to get OCD, temper tantrums, movement disorders, and tics, just as we see in kids with PANDAS. Although there are mixed results, animal and basic science studies lend support for PANDAS as a post-infectious autoimmune dysfunction. Some of the notable recent findings: we find T lymphocytes result from group A strep infections, which produce neuroinflammation and allow crossage of the antibodies across the blood-brain barrier. Usually the blood-brain barrier, we think, protects the brain. We don't allow antibodies to cross. But we are now finding that there is this production of these specific inflammatory T helper 17 cells, which produce interleukin-17, and they're very robust in the tonsils and in the adenoids, both in the human experiments and also in the mouse models. And then these can lead to brain inflammation. The Th17 cells and the interleukin-17 are also found in high amounts in the heart in patients with rheumatic fever. Antibody-mediated neuropsychiatric changes have also been induced in mice who have been exposed to group A strep. And then if you take sera, if you take blood from kids with PANDAS and you put it into mice, it will preferentially bind to the basal ganglia specific sites. And then if you treat those children with immunoglobulin, with IVIG, and then take their sera again and put it in the mice, it will no longer preferentially bind. So they're continuing to do a lot of work in this area, and there's promise for the development of specific biomarkers. This may even be published as recently as this spring out of Columbia through a conference that I heard, but this is still unpublished data. But there's also preliminary research that is showing a very strong association between PANDAS and certain HLA-B alleles. And this is being studied between a group that is both at Stanford and at Columbia, and they're hoping to publish this year as well. The challenge really has been to find a non-invasive, repeatable means to detect the neuron inflammation. So these are the recommendations for PANS evaluation and treatment. As always, a complete history and physical exam are important. Remember to include evaluation for possibility of abuse, bullying, or trauma in these children. It is notable that in the family history and the child's past medical history, there is a higher incidence of all types of autoimmune disease and neuropsychiatric disorders, including rheumatoid arthritis, celiac, vitiligo, thyroiditis, type 1 diabetes, and OCD and tics. Remember to elicit a recent history of illness or infection in the family members and other close contacts, and look for a temporal relationship between that infection and flares of this illness in the child. On physical exam, we look for some pertinent findings. If you see this child in an acute stage, they may appear inattentive or hyperactive or even fear-stricken. Pay special attention to lymphadenopathy or other signs of infection. On the skin, we can look for signs of excessive picking, washing, licking, secondary to OCD behaviors. Also look for vitiligo as evidence of other autoimmune diseases. That is one that my daughter actually has, and we didn't really realize it until all this had happened. Also look for a scarlatina rash. Look for impetigo, cellulitis, or other signs of strep. You can see dilated pupils with slow pupillary response to light, and look for otitis, sinusitis as well. Although they aren't the most common place we see strep infections, we can see otitis and sinusitis with these kids. On cardiac exam, really important to look for a new murmur to rule out the possibility of whether we have to be doing a full workup for rheumatic fever. The neurologic exam findings can be very subtle. You may see motor or phonic tics. The strength may be slightly weakened in proximal muscles, and they could be in a slouched position. Sometimes you would see a pronator drift if you looked for it. There's tenderness that can be elicited in the joints, muscles, and tendon insertions. The pain in PANDAS is not a frequent complaint because the psychiatric symptoms are so severe often that the family never mentions it. But when directly questioned, these children have significant polyarthralgias and fatigue. One study showed that 48% have a pain amplification syndrome, and 15% actually meet diagnostic criteria for fibromyalgia. Coriform movements can be seen. These are only going to be noticed with a careful physical exam. You can test for coriform movements in a Romberg position. If you have the child stand still, you may be able to see it in their fingers, but to really elicit it, you want to do a Romberg with feet together and arms outstretched and eyes closed. And if you, after a few seconds, hold up to 60 seconds, you may see some fine piano playing movement of the fingers. And this is coriform movements. Okay, however, if you see this, if you actually see actual chorea, then this is not PANDAS. This now meets diagnostic criteria for Sydenham's chorea. And I wanted to show you these videos because so many of us have not seen much rheumatic fever and certainly have not seen Sydenham's chorea. But you see the weakness, you see the movements that are adventitious. And that child was still able to walk. This is reported in New England Journal of Medicine. These children with Sydenham's chorea also have associated psychiatric. Yeah, so some of the children will have, really severe weakened muscle tone with inability to walk at all. But if you see more than just a little fine movement, that needs cardiology and rheumatology and neurology evaluation to treat the full extent of that disorder. Plus, children with Sydenham chorea must have a long-term prophylaxis from strep, just as we would in rheumatic fever. The mental status and the affect is the most telling. These children have selective memory impairments. They often cannot recall details of their symptoms, and they do not recognize the impact on their functioning. Emotional lability is a hallmark symptom, characterized by involuntary and uncontrollable episodes of crying or laughing, rages, irritability, impulsivity, and aggression. Depression and lack of insight are common, particularly during the later stages of the illness, so the child may present with a flat or depressed affect. Regressed behavior, you may see baby talk, secondary to developmental regression, a paucity of speech, selective mutism, or the new onset of stuttering. A child psychiatrist may be elicited for a complete psychiatric exam. Some of the neurologic effect is dramatic. A sudden decline in handwriting is notable and helpful with diagnosis. You can obtain the child's school papers and compare writing to pre- and post-illness. This is a child writing very well and clearly before PANS, and then their writing becomes illegible during a flare. The fine motor skill abnormalities may be elicited in office by asking the child to write, draw, or copy simple figures. Here's another example of skills lost due to the regression from PANDAS. So there is no single laboratory test to be done for PANS at this time. Labs are done to exclude other conditions and also to prepare for treatment. Definitely do a rapid strep and a throat culture in all new onset of psychiatric symptoms that are acute. And definitely a throat culture, because we can see up to 17% missed on rapid strep. Basic blood work should be done. Blood dyscrasias are common. There is frequently leukopenia, lymphopenia, and thrombocytopenia. Check a vitamin D. It's also frequently low. ASO and anti-DNase B can be done to see if we see a sign of past strep. However, this really just offers clues. We need to see at least a 50% increase for it to be significant, and we would need to be doing serial tests 6 to 8 weeks apart. If the child is very sick and we see evidence of other immune dysfunction or even immunodeficiency, then we should consider immunology consultation and look at ANA, lupus, antiphospholipid antibody, and quantitative immunoglobulin panels. Low IgA is seen frequently in these children. We also may need neuronal antibody testing for things like NMDA receptor encephalitis, and also for thyroid antibodies. There are genetic links being found in certain HLA-B alleles, but this is still preliminary research at this time. Any pathogen has the potential to initiate PANDAS, but based on exam findings, consider skin, vaginal, and nasal cavity cultures. Perianal strep has been documented as a pretty common cause of acute onset of this disorder. So you can ask for a history of itching and consider checking. Also evaluate family members and other close contacts for symptoms of pharyngitis and infections. Lyme and other tick-borne infections, especially in our endemic area, can be common causes for PANDAS. We may want to look for mycoplasma pneumonia. Consider PCR if you have a history of the child or a family member with a persistent cough. Could look at influenza, Epstein-Barr, herpes simplex virus, and perhaps consider infectious disease consultation. The neuroimmune serology, you can test for the presence of cross-reactive antineuronal antibodies, and this may help to rule in or rule out PANDAS, but it is really still investigational testing at this time. Acutely ill children with PANDAS will have elevations of titers of antibodies against lysoganglioside, tubulin, dopamine 2, and dopamine 1 receptors. The antibodies also produce an activation of an enzyme called calcium calmodulin protein kinase 2, or also called CAM2 kinase. And CAM2 kinase is an enzyme which is involved in neurotransmission. The combination of these 5 tests is called the Cunningham panel. It's currently only offered at one CLIA lab, which is Molecular Labs. And it is available for clinical use. You can order it, but it is really still needs to be considered investigational at this time. For severely sick kids who are having delirium, encephalopathy, severe psychosis, we may need to pursue further tests. These tests are not going to be done to diagnose PANDAS. We are doing this in these sick kids to rule out more severe illnesses. A lumbar puncture and an EEG may be useful. An echo and EEG may be needed as per the rheumatic fever guidelines from American Heart Association. You might also consider MRI, PET, and sleep study. PET is only research at this stage and certainly would subject children to radiation. So there are very few studies being done in children with PET. However, there has been one study that was done, and they showed activated microglia when a certain ligand was used. That study was not done with glucose as we do in most typical PETs. Instead, it was using a ligand that was specific for activated microglia. Here is a case, this is a typical PET with glucose. Here's an example of PET scan pre and post treatment. In this case, you can see at the beginning, this child had a metabolic area in the basal ganglia. And they were very hypometabolic in the frontal lobes. After treatment with plasmapheresis, this is 4 months later, it's completely normal. MRI with T2 weighted images also indicate the area of pathology. Shown here in hot pink, the PANDAS kids may have larger basal ganglia volume in the caudate, the putamen, the globus pallidus than the controls, which are shown in the teal blue. So here you see their average is higher in each of these areas here, but not in the thalamus. And also when they looked at the total brain size, there's no difference between the controls and the PANDAS, just in the basal ganglia areas. Sleep abnormalities are very common with high rates of fatigue. Sleep study with attention to neurologic parameters is abnormal in 87% of kids with PANDAS. They have insomnia, nightmares, restless sleep, and reverse cycling. 80 to 85% have what's called REM behavior disorder. This is when you have movements while you're sleeping. This is an objective finding on sleep study and can be very useful when the diagnosis is questionable. General principles for treatment have been established by the PANDAS Consortium and were published in 2017. They are seen here. Treatment of this complex disorder needs to be individualized to the patient's primary symptoms and focuses on ameliorating the current symptoms in the current episode and preventing future episode. This is the three-pronged approach with these three complementary modes of intervention. They typically all have to be addressed at the same time. We need to treat the symptoms with supportive interventions, psychotherapy, and symptomatic medications. We need to remove and treat the source of infection with use of antimicrobials, and we need to treat the disturbance of the immune system with anti-inflammatory or immunomodulatory therapies. The first prong is the supportive and psychotherapeutic interventions. Treatments to reduce inflammation and infection may be the most important part to address the root cause. However, in the meantime, these children and their families are really suffering. They can be extremely ill with psychiatric behaviors and need urgent interventions while their brain is inflamed and while our medical workup is being completed. Symptomatic treatment is needed to help the family manage difficult behaviors, crisis, suicide and injury prevention, school accommodations, sleep hygiene. We need to treat pain. We need psychotherapy and education for the parents and families. In children with severe food restriction, maintaining adequate nutrition is a priority. They may need feeding tubes, hospitalization, occupational therapy to retrain swallowing. New PANDAS psychiatric symptoms are likely caused by inflammation, and they do not respond well to psychopharmacologic interventions. These children frequently have an atypical response to psychiatric drugs. The studies have reported an increased activation and worsening of behavior when given SSRIs, with frequent suicidal ideation. So great caution is recommended. It's also difficult to discern between medication effect due to the episodic course of PANDAS and the medication side effects when we're giving these medications concomitant at the same time with immunomodulatory and antibiotic therapies. Sometimes benzodiazepines and frequently NSAIDs and antihistamines are used on a PRN basis to temporarily ease difficult rages and anxiety. Psychology and therapy services are certainly needed for these families. Cognitive behavioral therapy, exposure response prevention, and parent management training are all evidence-based strategies to aid in the reduction of OCD rituals and to help treat anxiety. Habit reversal training is also used to decrease tics. The cognitive behavioral therapy often has to actually be started with just the parents because the children are just too ill to be able to participate. But the family can learn strategies to help to treat their child's OCD and to help care for the child, and then as the child gets better, they can hopefully participate in cognitive behavioral therapy as well. Parent management training is technique used in OCD to train the parents to not participate in the child's avoidance rituals and to help them to continue to try to engage in their ADLs as typically as they can. So the antimicrobial treatment is the second pillar of therapy. An initial course of antibiotics is recommended for all PANS cases. This is even when we don't have a documented infection. This is the same approach that we use for all new acute rheumatic fever. So we are to test all children for strep during the initial workup, even if there are not clinical signs of pharyngitis. And then we repeat testing during times of flares. There is evidence of therapeutic benefits of antibiotics in PANS, both with and without an infectious trigger. So even in the kids who we don't think it's caused by strep, they seem to still respond to a treatment with antibiotics. Children have experienced complete and lasting remission of their symptoms with antibiotics treatment. Family members in close contact should also be swabbed even when they are asymptomatic. Group A strep is the most common infectious trigger, and most children have had strep 3 or 4 times before they present with the initial episode that's associated with neuropsychiatric disturbance. The more episodes of previous strep, and then the more severe and the more frequently we see relapses. The objective of antimicrobial therapy is to eradicate the current infection and prevent the non-suppurative sequelae such as rheumatic fever. The first choice is penicillin. If there's allergy or intolerance, we can use cephalosporins or azithromycin, as recommended according to the IDSA guidelines for group A strep. Azithromycin may be less effective due to resistance rates as high as 5 to 10%. However, it does have the advantage of having an immunomodulatory effect, and sometimes better results have been seen with that. It also has very good activity against mycoplasma, which is another common trigger for PANS exacerbations. Studies of response to antibiotics have been mixed, but they have shown efficacy in reducing or completely stopping neuropsychiatric symptoms in many cases, especially when it is given at the very first onset of the neuropsychiatric symptoms. For example, the Rochester group, a pediatric group there, they reported a case study of 12 children. All these studies are small. It's a rare, still not well studied in these cases, but all 12 kids. This is a clinic that is treating a lot of kids with PANS and PANDAS. So these 12 that they treated immediately as soon as that OCD and severe anxiety started, and all 12 had complete remission with just a simple course of 3 weeks of antibiotics. Secondary prophylaxis, as we do in rheumatic fever, this is not currently recommended according to the guidelines for all children with PANDAS. However, there is, by using prophylaxis, a potential to prevent neural injury from future group A strep infections. And the consortium does recommend using prophylaxis for severely affected children or children who have multiple exacerbations. When it is decided to institute prophylaxis, we use the guidelines for rheumatic fever and also consult infectious disease. Prophylaxis is often continued for 1 to 2 years after resolution of symptoms and possibly to age 18. Consideration given to discontinue prophylaxis during the summer months sometimes, but that is also not in guidelines. Some authors, including the recommendations in Up to Date on 2018, that author does recommend using antibiotic treatment in these children as a useful diagnostic tool to see how they respond to diagnostics. If they have a clear response, that's going to lend you more towards the diagnosis. Let's see. I will not run through all of the antibiotic studies. I certainly have all the references available if anyone's interested. Many people have asked me about my daughter's tonsils, so I wanted to mention that. There are no prospective controlled studies, but there are small case series that suggest improvement with adenoid and tonsillectomy. In one small study, 4 out of 9 patients had complete resolution of their neuropsychiatric symptoms after tonsillectomy. So the guidelines are to follow the general guidelines that we use for general population for removal of tonsils and adenoids in relation to sleep apnea and recurrent group A strep. Immune modulatory treatments are used only in cases where there's clear evidence of neuroinflammation and post-infectious autoimmune dysregulation, which actually occurs in 75 to 80% of these kids, most specifically in the PANDAS subgroup. Guidelines for use of anti-inflammatories and immune modulation are based on decades of experience with their use in treatment of other autoimmune conditions that can be relapsing and remitting, such as asthma, reactive arthritis, neuropsychiatric lupus, vasculitis, and Sjogren's. The guidelines were created dependent upon the severity of the symptoms for mild, moderate to severe, and extreme life threat. I will mention these briefly, but consultation with neurology, immunology, and rheumatology is suggested when considering these. It is very important that before initiating immunomodulatory therapy, that a complete inflammatory brain disease workup is done. For mildly impairing PANS, the most appropriate treatment may be supportive therapies. But if symptoms persist, non-steroidal anti-inflammatory drugs such as ibuprofen and naproxen or short oral corticosteroid bursts are recommended. For moderate to severe cases, intravenous immunoglobulin is often the preferred treatment, but sometimes corticosteroids are enough. For PANS with extreme and life-threatening impairment, plasmapheresis is first-line therapy, and it can be given alone or in combination with IVIG and high-dose steroids. Rituximab is also used off-label. In each of these cases, the sooner the treatment is initiated, the shorter the flare and the greater the response. Further support for our autoimmunity hypothesis is provided by clinical response to these immune modifying therapies. So multiple studies have shown significant improvement and complete remission of all symptoms after treatment with IVIG and plasmapheresis in children with PANDAS. It is really important to note that immunotherapy has not been shown any benefit in children who have a more gradual onset garden variety OCD or tics. Again, it is worth checking vitamin D. This is often deficient in these kids. So PANDAS is still thought to be a rare illness. However, its incidence is suspected to be 1 in 200, and to account for 10% of childhood OCD, it is suggested that it is not actually that rare, just rarely diagnosed. When a child presents with a sudden onset of emotional or behavioral symptoms to their doctor, they are frequently given a psychiatric diagnosis. A label of anxiety, ADHD, OCD is neatly applied, and common psychiatric drugs are prescribed to the child who is already emotionally disturbed. These labels describe the child's symptoms, but they do not identify the root cause of those symptoms. If the PANDAS child is not treated for the underlying cause, but instead is given SSRIs to treat anxiety, OCD, the drugs may have their expected effects, which can include hyperstimulation, anxiety, mania, and the child might become more aggressive, even violent. It might be thought the child is getting worse, not that they are being negatively impacted by the medication's unintended effects. If the PANDAS child is given stimulants, his behavior might shift from hyperactivity and agitation to apathy. They are likely to experience any of the combination of effects listed in those medications package inserts, including loss of appetite, lethargy, insomnia, tics, mood swings, and psychotic episodes. If he did not already meet the criteria for PANDAS, he might now with the addition of psychotropics. Unfortunately, the root cause is missed as the child is worsening. My primary goal today was to make you aware of this condition. It's my hope that when you hear of a child with a sudden lightning-like change in personality, that you ask that you first evaluate them for strep, and that you ask, have you considered PANDAS, just as was eventually asked of me a year ago. The guidelines do suggest that in most cases, the primary care provider will be able to treat PANS symptoms effectively with guidance from the guidelines and from consultants, especially when they're caught early and treated with antibiotics. However, children with severe symptoms and complex presentations may require specialized treatment by an experienced multidisciplinary team. There are many resources available. There are now dedicated PANS clinics in all of these universities. And there's also a group called PANDAS Physicians Network. If you guys pick up these pamphlets, PANDAS Physicians Network has a list of directory of physicians. They also have a Google group which you can join, and you can ask any questions of this group. And the lead researchers in this field, they respond to those questions on a regular basis. Also, a free CME program was just released by Stanford, and the link to that is here if you'd like to learn more. So thank you very much, and please feel free to contact me for my resources if you're interested in having my resource list, and also if you're interested in my slides. So thank you very much. If there's any questions, I guess you have a couple minutes. Yeah, I'm happy to